Hello guys, good evening. Can you all see me? Can you all hear me? Can you all see me? Can you all hear me? Please cover part 2 of GIT. Alisha, we have scheduled the part 2 of GIT. That is going to be, I think, on the upcoming week, which will definitely do so. So today we'll be covering urology. So what are the topics that we're going to cover in urology or your previous exam questions? Just quickly look through it. So we'll talk about all the short note first. The short note which is usually asked in your exams is about, number 1 is phimosis. Number 2 is paraphimosis. I'm talking about in the order which is usually asked. Second, I've asked you on horseshoe kidney. On the horseshoe kidney, hydrocele. On the horseshoe kidney, hydrocele. Then they've asked you on BPH also, like a short note only. We'll try to talk about all those. Just give me 1 second, guys. Just hold on for a second. All right, so I was saying the short note is about phimosis, then there's paraphimosis, horseshoe kidney, hydrocele, BPH. The long questions that we have, number 1 is about nephrolithiasis. There is nephrolithiasis. Then there is hydronephrosis. Then there is about Wilms tumor. There's about Wilms tumor. I think then, so there's nephrolithiasis, hydronephrosis, Wilms tumor, and testicular tumors. So these are the questions which are usually asked. So these were our short questions which are of 5 marks each, and few of them are 3 marks, and this is usually a 10-mark question. This is usually a 10-mark question, right? So our objective Hi guys, good evening. So our objective is to cover all these topics from the exam perspective. We'll start whatever is in the kidneys first. We'll talk about the horseshoe kidney, we'll talk about nephrolithiasis and the hydronephrosis, and then we'll talk about Wilms tumor, of course, are the one from the kidney. Okay. So starting with the first discussion, that is going to be on our renal component. So when you talk about the congenital disorders of kidney, one of the most important is going to be the horseshoe kidney. So first of all, when you write a horseshoe kidney, remember it's a congenital anomaly, but it's a combination of 2 different anomalies, right? What are the 2 different anomalies that it is going to take? It is going to be a combination of anomaly of fusion. There's an anomaly of fusion. Along with that, there is presence of anomaly of ascent. So there is this anomaly of fusion is present. Along with that, there is anomaly of ascent. What do you mean by this anomaly of fusion and anomaly of ascent is? For that, you can draw small diagrammatic representation saying that if this is the abdomen and the pelvic region, this is the scrotum, just for the sake of understanding. You will notice whenever the kidneys are going to develop, they are going to develop in the corresponding iliac fossas. They are going to develop into corresponding iliac fossas. When the kidneys are developed, they are going to ascend to their respective positions, right? So development of the kidney occurs in the corresponding iliac fossa. When the development is complete, they ascend up, they align themselves, and this is the usual progression on the embryonic basis. Now, horseshoe kidney occurs when the lower segments, so usually we talk about the lower poles. It can be mid pole, upper pole also, but when the kidneys are going to develop in the iliac fossa and they're close and they're so close to each other, now because they're close to each other, there's a probability that they can fuse with each other. So in a horseshoe kidney, when you look at these two anomalies put together, you will notice that this is how the kidney is going to get fused. This is how the kidneys are going to get fused, and this is how it is going to look up. So this is going to be the pelvicalceal system, and this is going to be the ureter. So this is the pelvicalceal system that you have, and this happens to be the ureter that is going to be present. Now if you see carefully, if you look at carefully, this middle part of the kidney which is fused, or the part of the kidney which appears to be fused, this is what we call it as the hilum of the horseshoe kidney, right? So you can see there's an anomaly of fusion and there's anomaly of ascent. Though ascent is not able to go upwards. Now in a horseshoe kidney, the first thing first, you can label it saying that this is the isthmus of the horseshoe kidney. This is the isthmus of the horseshoe kidney. And remember, if you look at the presentation, it is going to be between L3, L4. So with respect to the vertebral position, the horseshoe kidney is found anywhere between L3 to L4, right? Now they'll ask you, we all understand the anomaly of fusion is because there is a close proximity. Why is there anomaly of fusion? So you need to understand that this is the aorta which is running behind the kidney. So this is the orientation of the aorta which is running behind the kidney. So you see this is the aorta. This is the aorta which is running behind the kidney. So obviously all the renal arteries and everything, I'm not going to talk about it, but it's a blood vessel that is going to originate from the aorta and overrides. It goes above the isthmus of the horseshoe kidney. Now this blood vessel that goes on top of the isthmus of the horseshoe kidney, this is your inferior mesenteric artery. This is your inferior mesenteric artery. Now they ask you what is the anomaly of fusion, anomaly of ascent. Remember, it is anomaly of fusion. Anomaly of fusion is due to close proximity of kidney during development. Is going to result in anomaly of fusion. Anomaly of ascent. The anomaly of ascent is due to inferior mesenteric artery overriding isthmus of the horseshoe kidney. Isthmus of the horseshoe kidney, right? So there are two important components. The anomaly of fusion. Hi Sam John, good evening. I'm good, thank you for asking. Continue on our discussion. So we have the anomaly of fusion is because of close proximity. Anomaly of ascent is prevented. So it is the horseshoe kidney and this is your inferior mesenteric artery. It is not allowing the horseshoe kidney to rise up. Okay, as simple as that. Now, when they ask you, we all understand, okay, this is all about horseshoe kidney. We do understand that it is not able to ascend upwards, right? Now, if you look at the clinical presentation of horseshoe kidney, what leads to the clinical presentation? Remember, more than 90% of the patients with horseshoe kidney are asymptomatic. They are asymptomatic. And those patients who are less than 10%, less than 10% of patients are symptomatic. And these are because of, not because of horseshoe kidney. They're not because of the horseshoe kidney. The symptoms are due to sharp angulation. It is due to sharp angulation at the pelvic-ureteric junction. The sharp angulation at the pelvic-ureteric junction. Now, what do you mean by this? So, normally when you look at the kidney, this is the orientation of the kidney, and this is how a pelvicalceal system would present, and this is how a ureter will be there, right? So, this is the anastomosis between the pelvicalceal system. So, this happens to be your pelvicalceal system, and this happens to be the ureter. The junction between these two, The junction between these two is what we call it as the pelvi-ureteric junction. This is what we call it as the pelvi-ureteric junction. And when you look at this angle, the angle between the pelvi-ureteric junction and the ureter is an obtuse angle. This is an obtuse angle. Now the reason the angle has to be obtuse is whatever urine that is going to be produced, whatever urine that has been produced by the kidneys, all that urine is going to be pumped up from the collecting system into the pelvic ulcer system. From there it flows into the ureter without causing any problem because the angle is so uniformly maintained, right? That's the basic concept behind having a normal angle. In a patient who's having a horseshoe kidney, see, normally the kidneys are face down, but when there's a horseshoe kidney, what is going to happen? This face down kidneys, when they fuse together, and the fusion is going to do like this, right? So this is how a kidney should have been face down, but when they move closer during the development, they're moving closer and they get entangled like this. When they get entangled like this is how a horseshoe kidney is formed. The kidneys are not able to face down, now they become face up. Now because they are fused on the lower part, the face up of the kidney is going to happen, and that is the major problem in horseshoe kidney. So when it happens, so you will now realize this is how the horseshoe kidney would look like. Now because of this fusion segment, you now see this is the pelvic ulcer system, which is going like this, which is going to be here, and this is the ureter to which it is going to anastomose. Now I want you to observe the angle between the normal and this horseshoe kidney. So you see the pelvi-ureteric junction. So you saw the pelvi-ureteric junction of the horseshoe kidney has got a very acute angle. Problem is not acute angle. What is going to happen? Whatever urine is going to be present, especially in the dependent areas of the kidney, will not be able to drain and starts to pool out. Now in the kidney, see, wherever the urine is going to pool out, the stasis of urine will result in precipitation of stones, and that precipitation of stones is going to become symptomatic. Now because of sharp angulation at the pelvi-ureteric junction, I can simply say this sharp angulation, at pelvi-ureteric junction leads to incomplete drainage of urine. Now this incomplete drainage of urine will result in urine stasis. And when there is stasis of urine, it will result in precipitation of stones, and these are usually calcium oxalate stones. Now whenever a patient develops a calcium oxalate stones, any stone will be presented with obviously pain, that is ureteric colic will be there. Along with that, they'll be associated with hematuria. There will be presence of pain, there will be hematuria, there will be associated hematuria as well as dysuria. So these are the three symptoms, but in horseshoe kidney, all the symptoms are going to be recurrent. So be recurrent pain, recurrent hematuria, recurrent dysuria, all this is going to happen, right? Now, whenever you have a patient with recurrent ureteric stones, I would like to evaluate, right? So in terms of investigation, what are the investigations you can do? First investigation, you can do an ultrasound abdomen because the patient has presented to you with pain abdomen. Now when you do an abdomen, obviously you will see there is a presence of horseshoe kidney. So I would like to do a couple of more investigations. Now there's something called as an IVP, that is intravenous pyelogram. There's an intravenous pyelogram. Now this intravenous pyelogram, I am going to put the contrast into the IV. From there it goes into kidneys for excretion. It combines with the urine, it excretes. So when it excretes along with the urine, you will be able to map the entire scenario. So what is going to happen if you are going to do so? Now as we know, this is the horseshoe kidney. So this is the orientation of the horseshoe kidney. Just I'm going to keep it across here. And let's say this is the bladder that is going to be present across here. Now just for the sake of understanding, so this is the isthmus and this is the face up of the kidney. Now as this is a face up of the kidney, this is the pelvic ulcer system that we have, and let's say this is where the ureters are opening into the bladder, right? So this is where the ureters are opening into the bladder. Now we have given them the contrast, right? So this contrast is going to flow via these kidneys, and then it is going to go into the bladder. It will go into the bladder, it will fill up in the bladder. So in the x-rays, or when you take an image, I'll not be able to see the entire kidney. What I'll see is something like this. On one end like this, on the other end it is like this, and then you see something is happening like this, and there's a contrast which is going to fill. It looks as if I've put two flowers in a vase, right? And this is what we call it as the flower vase appearance. This is what we call it as the flower vase appearance. So this is what we call it as the flower vase appearance, right? So this is on the basis of IVP, right? But then if I have to confirm, remember the best investigation that you can do is going to be a CT urography. Do a CT urography and confirm the patient is having a horseshoe kidney, right? Now once you have confirmed the patient is having a horseshoe kidney, then you should say in terms of management. The management of horseshoe kidney is whether the patient is symptomatic or asymptomatic. If the patient is having an asymptomatic horseshoe kidney, or whether the patient is having a symptomatic horseshoe kidney. An asymptomatic horseshoe kidney patient, now what would you like to do? Do nothing. Leave the patient and ask them to enjoy. Symptomatic horseshoe kidney, if it is because of sharp angulation, then you have to do a pyeloplasty. Pyeloplasty for improving the angle. One such name of the pyeloplasty that you can remember, it is called as the Anderson-Hines pyeloplasty. You can do an Anderson-Hines pyeloplasty. So what you basically do in an Anderson-Hines pyeloplasty is the angle which is like this. This is the problem, right? This is the problem that we have. So with the help of pyeloplasty, I'll be able to make this angle somewhat like this. So I'm not changing it completely, but from a sharp angle, it now becomes an obtuse angle. And in obtuse angle, the drainage of urine is quite simple when compared to the acute angle. So this is what we call it as the Anderson-Hines pyeloplasty. This is what we call as Anderson-Hines pyeloplasty. So this is what you have to write when it comes for horseshoe kidney. Clear? Clear, guys? Quick feedback. ठीक है, चलो. Next comes is nephrolithiasis. Right. So when you talk about the nephrolithiasis is nothing but kidney stones, right? So it's the other name for nephrolithiasis are kidney stones. Before we start, you can simply write a statement saying that 90% of renal stones, 90% of renal stones are radio opaque. Only 10% of the renal stones are radiolucent. 10% of the renal stones are radiolucent. 10% of them are radiolucent, right? Now, when it comes down to the basic objective, that how do you differentiate them? You can write four. I will have a small comparison. We'll have 4 varieties of the kidney stones that we'll be talking about, right? Now, the first one we'll be talking about the calcium oxalate stones. So you can draw a small table. We have calcium oxalate stones. We have the phosphate stone. Then you have the uric acid stone. So we'll talk about 3 major ones. The other ones also cysteine and all that. So we'll talk about calcium oxalate stones, phosphate stones, and uric acid stones. They are the common stones that you will come across. Now when you draw the table, just make sure you present it well. So what are the data that I'm going to include in this table? Right. So you talk about each one of them. Let's talk about how they present to you. Remember all that we've told. The most common kidney stones, the most common renal stones is going to be calcium oxalate stone. Then I say the most radio opaque stone. The most radio opaque stone is going to be phosphate stone. The most common radio lucent stone. The most common radiolucent stone is the uric acid stone. So what are the causes? When you look at the causes for each one of them. Now talk about the calcium oxalate stones. The calcium oxalate stones are because of hypercalcemia, hypercalciuria, hyperoxaluria, hyperoxaluria. This is hypercalcemia, hypercalciuria, hyperoxaluria are the basic reasons for development of calcium oxalate stones. Phosphate stones is because of infection and it is because of the protease bacteria. It is because of protease bacteria, and we all know protease is a urease producing bacteria. It is a urease producing bacteria. What does urease does? It converts the urea into ammonia. It converts the urea into ammonia, and obviously ammonia is going to be lipid soluble and it is going to combine with the urine also. Now because of this ammonia that is being formed, it will result in alkaline urine. Now because of ammonium crystallization, it will result in precipitation. It will result in precipitation of stones. Uric acid stones is because of excessive excretion of uric acid in the urine, and uric acid is a byproduct of purine and pyrimidine denaturization. That means basically when the DNA deintegration occurs, purines and pyrimidines gets deintegrated, you will have the development of uric acid, right? Now what are the conditions where you have this? Number one, it is seen in gout. Number two, it will be seen in all your myeloproliferative disorders. So it is seen in gout, it is seen in myeloproliferative disorders. Another one is a Lish-Nyhan syndrome. So the Lish-Nyhan syndrome is a combination of gout with self-mutilation. It's a combination of gout with self-mutilation, and that is with respect to uric acid stones. So these are the various causes. Now, when you talk about what are the characteristic features, when you talk about the characteristic feature, calcium oxalate stones, they are round to oval in shape. They're round to oval in shape. They're usually dirty white in color. And they have sharp projections over their surface. There's sharp projections over their surface. So round to oval in shape, dirty white in color, and sharp projections. Now here it will be presented with ammonium salt. It will have magnesium salt as well as the phosphate salt. Because the three different salts, it is also called as the triple stone. This is also called as the triple stone. The other names that it is given to us is what we call it as the struvite stone. Because it damages the entire parenchyma, then the patient becomes symptomatic. This is also called as the silent stone. So you have the triple stone, struvite stone, silent stone. It takes the shape of the pelvic calcium system. So this is also called as the staghorn caliculi. This is also referred to as the staghorn caliculi. Uric acid stones, on the other hand, uric acid stones, they are formed in acidic urine. They're formed in acidic urine. They're just a crystalline form. So uric acid stones, they're very easy to treat because you don't need to go remove them. All that you have to do is, when the urine is becoming acidic, make it alkaline. So alkalization of urine is the treatment for uric acid stones. You don't need to go and disrupt it completely. So when you do a urine microscopy, so in urine microscopy, what type of crystals am I going to see? So in the urine microscopy, one second, just right, in urine microscopy, the crystals that you will see here, if you have a calcium oxalate stone, in a calcium oxalate stone, you will see a crystal which is like this. This is what we call it as the envelope shaped. It's an envelope shaped crystals. If another variant of this, that is a calcium oxalate monohydrate. If there is a calcium oxalate monohydrate, then this is going to be dumbbell. So this is going to be a dumbbell shaped crystal. This is going to be a dumbbell shaped crystal. So calcium oxalate will be an envelope shaped crystal. It will be an envelope shaped crystal, and the monohydrates are going to be dumbbell shaped crystal. Phosphate stones will have a crystal image which is going to be like this. So this is what we call it as the coffin lid. This is going to be coffin lid, right? And your uric acid stones, either they will be multi-faced, something like this, or they will have a rosette pattern. Either they have a multi-faced or they have a rosette pattern. Either it's a multi-faced or is it going to be a rosette pattern? It's going to be either a multi-faced or a rosette pattern. That is going to be on a urine microscopy. So these are the basic details on the nephrolithiasis that you have to give. Next comes the important aspect, the clinical features of nephrolithiasis. Clinical features of nephrolithiasis. What are the clinical features of nephrolithiasis, right? So any patient who is going to have nephrolithiasis, they usually present to you with ureteric colic. So it is the ureteric obstruction. Now if you take this as a representation of the kidney, take the representation of the pelvic calcial system, and this happens to be the ureter, and this is going to go and open into the bladder. Now take this as a representation of the bladder. I can divide the ureter into three halves, that is the upper 1/3, the middle 1/3, and the lower 1/3. This is the upper 1/3, there's a middle 1/3, and there's a lower 1/3. Now imagine there's a stone that is present in upper 1/3, in the middle 1/3, and the lower 1/3. We'll have to see that how does the patient present to us. So we are looking at the presentation per se. Now the first thing and the foremost, or the first and foremost presentation would be presence of pain. Now the question is, where is this pain? So patient will have sudden severe onset. There is sudden severe onset of radiating pain. There is sudden severe onset that is going to exist as the radiating pain. The question is, where does the pain radiate to? And the answer is going to be the pain will radiate in whichever way the stone is going to be, or whichever side the stone is going to present. For example, if the stone is present in the upper 1/3 of the ureter, it is going to arise from the flank. The pain will be in the flank, that is behind in the kidneys. From the flank, it is now going to go into corresponding testes. Whichever side the testes stone is present, that's a testes, the pain is going to radiate. If it is the middle 1/3, the pain will originate in the flank, but this time it will radiate to that of the iliac fossa. It will radiate to that of the iliac fossa, hypogastrium, as well as groin. So this is in the middle 1/3. If the stone is present in the lower 1/3, again it will start as a flank pain. It will then radiate to inner aspect of the thigh. It will radiate to the inner aspect of the thigh, to the scrotum, as well as to that of the perineum. Right? So it is going to radiate to that of testes, then to the iliac fossa, hypogastrium and groin, inner aspect of the thigh, scrotum as well as perineum. Right? So these are the context that you are going to see with respect to that of the perineum per se. Clear? So the first and the foremost was radiating pain. Along with radiating pain, the second symptom the patient will complain about is going to be hematuria. Along with hematuria, it will also have dysuria. The pain is so troublesome that it will also be associated with nausea as well as vomiting. Now that ureteric spasm will cause irritation of the bladder, which cause increased frequency. There will be increased frequency of micturition. There is this increased frequency of micturition. Now a patient with pain, there's associated hematuria is there, there's dysuria, there's nausea, vomiting, as well as increased frequency of maturation. All these tell you the patient is suffering from ureteric colic. Okay? Now how would you like to evaluate? In terms of investigation, the first one that you would like to do is going to be an X-ray KUB. That is kidney urinary bladder, because 90% of stones are radiopaque. Then you are going to get an ultrasound. Now ultrasound is done to rule out the presence of hydronephrosis. Now when you do an ultrasound, it tells you the size of the stone, it tells you the site of the stone, and it also tells you a stored urine. Now when I say stored urine, it is hydronephrosis. So stored hydronephrosis. So size, site and stored urine. So there are 3 S that you will see from an ultrasound. So when you do an ultrasound, this is the information that your radiologist is going to give it to you. Another investigation that you have is going to be an IVP, that is an intravenous pyelogram, which will tell you about the obstructive status. Now the next one that you have is going to be an NCCT, or you can do a CT urography. Now this is the most sensitive and the most reliable investigation in terms of ureteric colic. Okay? Now to assess the renal function, you need to do other investigations also, but for the kidneys perspective or renal stones perspective, these investigations are more than enough. They're going to be more than enough, right? So once you have determined it's a stone, how would you like to manage? So talk about the management of nephrolithiasis. So we'll talk about the management of the nephrolithiasis, right? So when you say the management of nephrolithiasis, it all depends upon the size of the stone. This all depends upon the size of the stone. So when you say this all depends upon the size of the stone. So first, let's say if you have a patient stone less than 5 millimeters in size, then you have size between 6 to 20 millimeters in size, and then you have a patient where the size is more than 20 millimeters, right? So this is the size of the stone. If it is less than 5 millimeters, then it is going to be conservative management. Then it's going to be conservative management. So in the conservative management, no, what are you going to do? I will give oral fluids, analgesia, antispasmodic, so oral fluids, analgesia, antispasmodics. Oral fluids, analgesia, antispasmodics. So oral fluid is to give adequate hydration, analgesia for pain, antispasmodic to relieve the spasm in the ureter that is present. Along with that, if required, you can give IV fluids, preferably normal saline with Lasix. It's a diuretic so that it can flush out the entire stone, and this is what we call it as the hydrotherapy. It's a hydrotherapy. Now, if it is stone between 6 to 20 millimeters, I will divide them into less than 15 millimeters or more than 15 millimeters. If it is less than 15 millimeters, then we'll do an ESWL. What does ESWL stands for? It stands for extracorporeal. It stands for extracorporeal shock wave lithotripsy. It's an extracorporeal shock wave lithotripsy, that is ESWL. If it is more than 15 millimeters, then you could do a URSL, that is your ureteroscopic stone surgery, or also called as the retrograde. It's a retrograde intrarenal surgery. It's called as retrograde intrarenal surgery, right? So RIRS, that is retrograde intrarenal surgery, that is a URSL, that is ureteroscopic stone extraction. If it is more than 20 millimeters, you have two options. Number one, you can go ahead with PCNL. PCNL stands for percutaneous nephrostomy, right? So PCNL, you'll do an opening in the kidney, that is, you do a nephrostomy and then you extract this stone. So it is percutaneous nephrostomy and then do a lithotripsy, that is to extract the stone. PCNL is going to be percutaneous nephrostomy and lithotripsy. This is what we call it as PCNL. Okay. So these are the management availability that you have. If you want to score extra bit, you can go ahead with contraindications with ESWL. When would you not advise a patient to go with extracorporeal shockwave lithotripsy? So in the ESWL, there's a machine that is going to generate shock waves. That shock waves are targeted where the kidneys, the stones are present. It basically blasts the stones and allow the stones to flush out. Okay. So what are the contraindications for ESWL? Number one, if the patient is obese. Number two, if there is a bleeding disorder. So there's an obese associated with bleeding disorder. if there is a distal ureteric stricture. If there is a distal ureteric stricture. So obese bleeding disorder, distal ureteric stricture. There's a distal ureteric stricture. If there is a low calyx stone, which cannot be extracted with ESW alone. Okay. And pregnancy, of course. In pregnancy, shock waves are contraindicated. So these are the conditions where you will not do ESW. Okay. So this is all that you have to write with respect to renal stones. This is all that you have to write with respect to renal stones. Clear? Okay. Okay. So we finished two important questions. So we finished the horseshoe kidney. We finished the nephrolithiasis, right? So let's go to hydronephrosis. So we'll talk about hydronephrosis. So by definition, hydronephrosis is aseptic. It is an aseptic dilatation of pelvic calcial system. It's an aseptic dilatation of the pelvic calcial system. Is this what called as hydronephrosis, right? Now this aseptic dilatation of pelvic calcial system, it may be due to complete or the partial obstruction of urine. So it's a complete or partial obstruction of the urine flow, and this is what we call it as hydronephrosis. This is what we call it as the hydronephrosis, right? Now, when you talk about hydronephrosis in general, if you want to know what exactly is happening, you can say this is the kidney which is present here. This is the normal pelvic calcial system that you will have, right? These are the major and the minor calyxes which are going to be collecting the urine, and this is the ureter. Now imagine there's a stone, and that stone is present here. Now as the stone is present here, it won't allow the urine that is present inside the kidney to go out. Now if the urine continues to pool, what is going to happen? This entire segment, that is your pelvic calcium system and the ureters, are going to dilate. Now this dilatation of the pelvic calcium system and the ureter, when you observe it closely, you now notice the entire pelvic calcium system with the ureter till the site of obstruction is going to be dilated. You see, everything which is present here is going to become dilated. It is going to get blunted, right? It's going to get blunted, and this blunting is also called as the soap bubble sign. क्योंकि पूरा यूरिन भर गया इसके अंदर, पूरा pelvic calcium system और ureter जहाँ तक आपका your stone is there, proximal to that, all that segment is going to become super dilated. Right? Super dilated. So this aseptic dilatation of the pelvic calcial system is what we call it as hydronephrosis. We call it as hydronephrosis. Now this can be because of a partial or a complete obstruction. It can be because of a partial or a complete obstruction. So we need to know what are the causes, right? So when you look at the causes per se, I can divide the cause into two categories. One which results in unilateral hydronephrosis, another one that results in bilateral hydronephrosis. So one that results in unilateral hydronephrosis. Causes that result in unilateral hydronephrosis and causes that results in bilateral hydronephrosis. Either it's going to be a unilateral hydronephrosis or it is going to be a bilateral hydronephrosis. Okay? Now, how do you know this? Now, easy way, rather than mugging up all the causes, we'll make a small diagrammatic representation. These are the kidneys which are present. Let's say this is the bladder, and this happens to be the urethra. I'm just taking the male of it, so it's easier for me to explain. And there's a prostate gland which is present here. These are the pelvic calcium system that we have, and these are the ureters which are going to. So these are the ureteric orifice. That means ureters open at this particular side. This is a pelvic calcium system. This is your pelvic calcium system. Now all that you have to do is draw a line that passes through the ureteric orifice. Draw a line that crosses through the ureteric orifice, right? Now once you have this line, remember any cause of obstruction that is above this line, this will result in unilateral hydronephrosis, and any cause that arises below this line is what we call it as bilateral hydroureteronephrosis. Okay? So above this line, the cause will be unilateral, causing hydronephrosis. Below this, it will cause bilateral hydronephrosis. Okay? Now, for example, if there's a stone which is present here, in this stone, what is going to happen? The urine will not be able to flow. So you will see all the urine that is present here is now going to pool up. All the urine that is going to be present here is now going to pool up, and this is going to be sitting across here. So this pooling of urine on one side, because obstruction is unilateral. But if imagine there's an obstruction somewhere at this particular side. Let's say there's a level of obstruction is here. If the obstruction is at this particular side, let's say there is something which is obstructing the contact side, the urine will not be able to flow. You see, the urine is going to have bilateral pooling. If the urine has a bilateral pooling, it will result in bilateral hydronephrosis. So based upon what level the obstruction is there, I know whether this is a unilateral or a bilateral hydroureteronephrosis, right? So when we talk about the causes that results in unilateral hydronephrosis, the most common cause is going to be stones. Along with stones, there will be ureteric stricture. It will be because of ureteric stricture. Pelvic tumors, which is causing lateral compression. This pelvic tumor causing lateral compression. Then urothelioma, that is the tumor of ureter. It is a tumor of ureter. PUJ obstruction per se, that is pelvic ureteric junction obstruction per se. Then cancer bladder. Cancer bladder arising from lateral wall. So you have stones, you have ureteric stricture, pelvic tumors, urothelioma, PUJ obstruction, and cancer bladder arising from the lateral wall. Cancer bladder arising from the lateral wall, that is a unilateral hydronephrosis. Now when it comes to bilateral hydronephrosis, what are the causes? Number one, it can be because of urethral stricture. So I hope everybody knows these are your ureters, and this happens to be your urethra. So we're talking about urethral stricture, bladder cancer. It will be secondary to bladder cancer, BPH, prostate cancer. So you have the urethral stricture, bladder cancer, benign prostatic hyperplasia, prostatic cancer associated with phimosis. Bilateral stones, bilateral ureteric stricture, and then you have Ormond's disease. Ormond's disease is idiopathic retroperitoneal fibrosis. It is idiopathic retroperitoneal fibrosis. It is a idiopathic retroperitoneal fibrosis, right? So these are the conditions that are going to be associated with hydronephrosis. Okay. Now, when a patient of hydronephrosis is present to you, what are the clinical features? Now, in a clinical feature, because the kidneys are going to swell up with filled up urine, it will be associated with flank mass. Now, as the kidneys swell up, the Gerota's fascia is going to stretch. It will be resulting in flank pain. It will be a flank pain. And whatever is the underlying cause, it will be associated with signs and symptoms of the underlying cause. So there's a flank mass, there's a flank pain, and there's a signs and symptoms. The signs and symptoms of the underlying cause. There's the signs and symptoms of underlying cause. Now that underlying cause can be stricture, stone, tumor, anything. But there's something which is going to be present, hydronephrosis. Hydronephrosis secondary to ureteric stones. Now hydronephrosis that develops secondary to that of the ureteric stone. That develops secondary to that of the ureteric stone. Secondary to the ureteric stone has something called as the Details crisis. There's something called as Details crisis, right? Now, what do you mean by Details crisis? In the Details crisis, initially when the stone is going to obstruct the kidney, that obstruction of the kidney will result in flank pain. It will result in flank mass. The presence of flank pain as well as flank mass when the obstruction is there. Then the patient is going to pass urine. Patient passes urine. After passing the urine, you will see the component of flank pain disappears and the flank mass also disappears. So Details crisis is what we call it as intermittent. This is what we call it as the intermittent hydronephrosis. So because when the stones are there, no, you will never have a single stone. So let's say one stone came today, it causes all the swelling. Because of the urine, the stone passes away. Another stone is going to come and lodge, and this time again it is going to form the same thing. So after passing the urine, the symptoms resolve, and before that it is appearing. So this is what we call as Details crisis or intermittent hydronephrosis. Presence of intermittent hydronephrosis tells you that you're looking at hydronephrotic kidney, right? Now, in order to know the renal perfusion, so in terms of investigations, what all can you do? Number one, you will do the ultrasound of the pelvic-ureteric junction, or I can say the KUB. After doing an ultrasound, I would see whenever you've done notice the patient is having a hydronephrosis, I need to know the cause also. So CT KUB should also be done. Now I need to know the renal perfusion. Now in order to assess renal perfusion, I will have to use the radioactive isotopes. One you have DTPA. One you have the DTPA. Another one is MAG3. DTPA is diethyl triamine pentaacetic acid. MAG3 is mercapto acetyl triglycine. Now remember, in terms of investigation, DTPA becomes the investigational choice for renal perfusion. MAG3 is the best investigation It is the best investigation for renal perfusion. So diethyltriamine pentacetic acid. Now, in order to assess the renal perfusion, you will usually prefer DTPS scan. So once you do a DTPS scan, I will assess the renal perfusion and we'll see if the renal perfusion is less than that of 10% or more than 10%. If it is less than 10%, or is it more than 10% of the perfusion. If it is less than 10%, then you have to take the patient for nephrectomy. If it is more than 10% of the renal perfusion is present, then you would salvage the kidney. But in either cases, remember, the management is always to treat the underlying cause. The management is going to be to treat the underlying cause. So hydronephrosis, remember, is not a disease, it's a presentation of an underlying disease. So as a note point, I can say hydronephrosis is not a disease. It's not a disease. It's a presentation. It's a presentation of underlying disease. The presentation of an underlying disease. Okay? So this is with respect to hydronephrosis, right? So we concluded another topic which was important from our exam perspective, and that is going to be hydronephrosis. That's going to be hydronephrosis. Okay? So we're left out with Wilms tumor, testicular tumor, 2 tumors, phimosis, paraphimosis, 1 condition, hydrocele and BPH. Okay? Chalo. So let's talk about the Wilms tumor. So let's talk about the Wilms tumor. Now, when you talk about the Wilms tumor, the Wilms tumor is also known as nephroblastoma. They're also known as the nephroblastoma. Wilms tumor is also known as the nephroblastoma, right? Now, when you talk about the Wilms tumor per se, the important features of the Wilms tumor, remember, Wilms tumor is an example of a mixed tumor. It is an example of a mixed tumor. It has both the components of epithelial component as well as connective tissue. It is a component of both epithelial as well as connective tissue. Wilms tumor usually arises, okay, it's usually, I mean, say it's a polar tumor. That means usually either it will be arising from the upper pole or the lower pole, but this is more or less like a Wilms tumor which is going to present here. Now, how does a baby of Wilms tumor is going to present to you? We'll talk about the clinical presentation. So when you have a clinical presentation of the Wilms tumor, in the clinical presentation of the Wilms tumor, the usual age of presentation is going to be 1 to 2 years of age, but almost every baby of Wilms tumor will present to you within the first 5 years of life. Within the first 5 years of life, right? Wilms tumor prediction is slightly more common towards the male child when compared to female child. How does a mother recognizes the patient has a problem? It will present to you as an abdominal mass. Now this abdominal mass is going to be palpable. It is going to be palpable, and this usually does not cross the midline. It usually does not cross midline. Now, what do you mean by that? It usually does not cross midline? As if you take this as a representation of the baby's abdomen, right? This is the midline which we are talking about. This is the umbilicus for the sake of understanding. We're saying the kidneys are situated here. This is the location where you have the kidney. Let's say there's a tumor that is going to arise. Wilms tumor, it is very growth wise, it is quite hefty. So even if it enlarges, it will enlarge at this particular side. Now you can see that no matter how much it enlarges, it is going to be limited to that of to the one side. So if it is on the right side, it will be on the right side. It usually does not cross the midline, right? So it's an abdominal mass which is palpable, usually does not cross the midline. It will be associated with painless hematuria. It will be associated with painless hematuria. Along with painless hematuria, it will also be associated with fever. There will be presence of fever as well, right? So there's an abdominal mass, there's a painless hematuria. Along with that, there will be presence of fever. Now, in Wilms tumor, it is more associated with the paraneoplastic syndrome. So what are the paraneoplastic syndromes associated with the Wilms tumor? What are the paraneoplastic syndromes associated with that of the Wilms tumor? Number one, you will see that there is an elevated ESR. It is associated with anemia. It is also associated, we'll talk about, it is also associated because of blood loss. Is, see, elevated ESR, I will not say much. Anemia will be there. It will be associated with anemia, and it is also associated. It's also associated with other disorders. Okay, for paraneoplastic syndrome, no. Okay, let's don't write the paraneoplastic syndrome for Wilms tumor because it's more associated with RCC when compared to Wilms, so we'll not confuse in that context. Okay, so it's a abdominal mass, also painless hematuria as well as fever. Now, when you say what is the classical triad, the classical triad is mass, mass, hematuria, and fever. So this is what we call it as the triad of the Wilms tumor. This is what we call it as the triad of the Wilms tumor. Right? Now, remember when you talk about the origin of the Wilms tumor, no, just for the sake of understanding, if I write the origin of the Wilms tumor, it is going to be originated from the three components which can be remembered as BEST. Now, what does BEST stands for? B stands for blastemia. E stands for epithelial tissue. And ST stands for stromal tissue. So there is blastemia, there is epithelial component, as there was stroma as well. There is stroma as well. Now, Wilms tumor is associated with a gene which is called as WT1 gene mutation. It is associated with WT1 gene mutation, and this is seen on chromosome number 11p13. Now, this WT1 gene mutation is also associated. It is associated with cryptorchidism. It is associated with the cryptorchidism, Hypospadias, as well as Wilms tumor. So it is cryptorchidism. It is associated with Hypospadias as well as Wilms tumor. So these are the components associated with WT1 gene mutation. Now, another thing that the Wilms tumor is associated with, it is associated with Vagar syndrome. So another component that you have with Wilms tumor is your Vagar syndrome. So what is your Vagar syndrome? Vagar syndrome is going to be a combination of Wilms tumor with aniridia, that is absence of iris. Then you have genital abnormalities, genital abnormality, and mental retardation. and the mental retardation. So there is Wilms, there is aniridia, there is genital abnormality as well as mental retardation, right? So that is going to be your Wagner syndrome. The other syndromes the Wilms tumor is associated with is going to be the Beckwith-Wiedemann syndrome. Beckwith-Wiedemann syndrome. Another syndrome that is associated is going to be Dennis-Drash syndrome. So when I say Dennis-Drash syndrome, it is associated with gonadal dysgenesis. Associated gonadal dysgenesis with nephropathy. And this nephropathy will result in renal failure as well. This nephropathy will result with renal failure as well, right? Now, in terms of investigation, what are the investigations that you're going to do? The first investigation is going to be the ultrasound of the abdomen. Second, I'll get a CT urography. And I'll say a renal biopsy. Do a renal biopsy. How do you manage? Management of your Wilms tumor is going to be nephrectomy, that is surgery. Surgery here we have to remove the kidney, that is going to be nephrectomy has to be performed. Along with nephrectomy, I will give a chemotherapy. Now the drugs that are approved for Wilms tumor, the drug that is approved for the management or the chemotherapy is what we call as the VDA drugs. V stands for vincristine, D stands for doxorubicin, and A stands for actinomycin. Right, so these are the chemotherapeutic agents for Wilms tumor. So if they ask you about Wilms tumor, this is the entire story that you have to write, starting from how it is presented, what are its clinical presentation, what is its other components, investigation as well as management. Okay? So that is with respect to Wilms tumor. So we have completed Wilms tumor as well, right? So Wilms tumor is gone. Now, the small ones, which are your phimosis, paraphimosis, hydrocele, all these are going to be just a definition. So we'll start with small components and then we'll pick it up from there. The first one is going to be the phimosis. So phimosis is defined when a foreskin of the prepuce, when the foreskin of prepuce is fused and fails to retract back, or fails to retract over the penis, over the glans penis, is what we call it as phimosis. Now, when they say what is the causes? The causes that leads to phimosis. One, we have a physiological phimosis, another one is a non-physiological phimosis. Physiological phimosis, another one is the non-physiological phimosis. One, there is a physiological phimosis, another one is a non-physiological phimosis, right? So when you say physiological phimosis, that means, see, until a certain age, around 2 to 3 years, so age less than 2 to 3 years, we say the phimosis physiological. Anything beyond that should be considered because of some reason. Non-physiological is all acquired, and the causes here is going to be poor hygiene of the penis. Now it's a poor hygiene of the penis because of excessive smegma deposit. There's an excessive smegma deposit. It is secondary associated with a condition called as BXO, that is Balanitis xerotica obliterans. BXO is your Balanitis xerotica obliterans. Then it is associated with trauma to the prepuce. Trauma to the prepuce and prepusal malignancy. And the prepusal malignancy, right? Now, how do they present to you? Clinical features. Number one, there will be presence of poor stream of urine. Now, because it is blocking the urethral opening, no, and that opening blockage will not allow the urine to pass freely, so there will be presence of poor stream of urine. Along with poor stream of urine, there will be presence of ballooning of prepuce. There will be ballooning of prepuce, right? So there will be poor stream of urine, ballooning of prepuce in adults. There will be difficulty in intercourse. There will be difficulty in intercourse. If the patient does not get treatment, it is now going to get into complications. The complications associated with that of phimosis. The complications associated with phimosis is going to be balanitis. It is the inflammation of glands. Then you have balanopostitis. That is inflammation of glands as well as prepuce together. Development of prepusal caliculi. Development of prepusal caliculi, and there is increased risk for penile cancer. Increased risk for penile cancer. So management for all patients of phimosis, it is going to be surgery, that is going to be circumcision. So you have to go ahead with circumcision, right? So this is what you'll write about phimosis. Okay. Next is about hypospadias. So we'll talk about the hypospadias. Hypospadias is defined as it is an abnormal, there's an abnormal opening of urethra onto the ventral surface of the penis. Onto the ventral surface of penis. So there is an abnormal opening of the urethra onto the ventral surface of the penis is what we call it as hypospadias, right? So for the sake of classification, look at the classification of hypospadias. Take this as a representation of the penis. This happens to be the scrotum. This is the midline. This is the glans. This is the shaft of the penis. This is the coronal sulcus, and this happens to be the glans penis, and this is the urethral meatus, right? Normally, we would expect that the urethra should open here. So this is the normal opening of the urethra that is expected. Now, if it opens here, or if it opens here, if it opens here, if it opens here, if it opens here, all these are your abnormal sites, right? Now, if it opens here, this is what we call it as the glandular type. This is what we call it as the glandular type of hypospadias. This is normal. If it opens on the coronal sulcus, it is called as the coronal type. If it is opening on the shaft of the penis, this is what we call it as the penile type. If it is opening between the penis and the scrotum, it is called as the penoscrotal type. If it opens between the two scrotums, this is called as the interscrotal variety. This is a interscrotal variety. So you have the glandular type, you have the coronal type, you have the penile type, you have the pinoscrotal type, and the interscrotal variety. Right? All these are the various contexts or the various varieties of the hypospadiasis. The various varieties of the hypospadiasis. Okay. Now, when you talk about what is the clinical presentation of the hypospadiasis, I'll just list it down here. Clinical features. There'll be an abnormal opening of urethra. There'll be an abnormal opening of urethra. Along with that, you will notice that distal to the urethral opening, that will become fibrotic, and that is called as chordae. So there is presence of a distal chordae. Now, because of distal chordae, it will result in ventral fibrosis. This will result in ventral fibrosis. And this ventral fibrosis of the penis will result in ventral bending of the penis. This will result in ventral bending of penis. This will result in ventral bending of the penis. So there's an abnormal opening of the urethra. There is a distal chordae. Along with that, there will be presence of hooded prepuce. There will be presence of hooded prepuce, right? So there's an abnormal opening of the urethra. There's a presence of distal chordae. There's presence of hooded prepuce, and it is also associated with meatal stenosis. Now, presence of meatal stenosis. Presence of meatal stenosis will result in poor stream of urine. Will result in poor stream of urine. Now, for hypospadiasis, the investigation is going to be clinical examination. It is going to be clinical examination. It is going to be clinical examination. Now, when you talk about the management, now the management options that we have, number one is going to be your orthoplasty of penis. This orthoplasty of penis, it is to correct the penile chordae. It is to correct the penile chordae. Then you have urethroplasty. It is going to be the urethroplasty. For a glans reconstruction, you will do a granuloplasty. You'll do a granuloplasty. Then you have other repairs. Number one, you have just remember the name, which is called as the Matthew repair and the magpie repair. Magpie is meatal advancement granuloplasty. It is called as the meatal advancement granuloplasty. Right, that's the magpie. Matthew repair and the magpie repair is a single stage surgery. It is a single stage surgery. Then you have called as the TIP surgery. TIP stands for tubularized incised plate surgery. It is a tubularized incised plate surgery. Another one that you have is your Snodgrass. What is it? Snodgrass repair. And the last one that you have is Dennis Brown repair. It is a Dennis Brown repair, right? So all these are the managements of your hypospadias. Okay? Chalo. Next comes is your hydrocele. Now for hydrocele, I can define it by saying that there is excessive collection of fluid. There is excessive collection of fluid between the tunica vaginalis, and testes due to increase in secretions, or decrease in absorption. So there is an excessive collection of fluid between the tunica vaginalis and the testes due to either increase in secretion or there is decrease in absorption per se, right? Now, what are the causes, or how can I quantify that what is happening in the hydrocele is on the basis of certain causes? So we divide them into two categories. One is a primary cause, another one is your secondary cause. Now the primary cause is still considered to be idiopathic. The primary cause is what is unknown, so it is still considered to be idiopathic. The secondary causes for the hydrocele, it is going to be filariasis, which is the most common secondary cause. Then it is tuberculosis, and then you have tumor. So you have the filariasis, tuberculosis, and the tumor that will result in hydrocele. Now, based upon the various components, there are three different types of the hydrocele that you have. In fact, I'll put it as four, the four different types of hydrocele. Now, if you take this as the representation of the inguinal canal, this is the deep ring, this is the superficial inguinal ring. So just take this as a representation of the inguinal canal. The four different varieties of the hydrocele that we can list out. Now, the first variety that you see, if you take this is a representation of the testes. So all these is the representation of the testes. For the sake of understanding, this is going to be deep inguinal ring. This is your superficial inguinal ring. This is your deep inguinal ring. This is your superficial inguinal ring. This is your deep inguinal ring. This is your superficial inguinal ring, deep ring, as well as superficial inguinal ring. Now you see this is how the cord is going to be present. So this is the vas deferens. This is the vas deferens that is present. And then this covering is what we call it as the tunica vaginalis. Okay? Now in the first variety, you see there's an excessive fluid that is going to be collected, but that is going to be around the testis. This is your first variety. Then you see that the collection is going to become so severe, but then it reaches to superficial inguinal ring, but never beyond this. Then you see there's another variety where there is an intra-abdominal communication and the swelling is going to be in this particular format. And there's one that is going to be only present in the cord. Now, the one that is confined to testes itself, is what we call it as the vaginal type. One that is going to be going all the way to that of superficial inguinal ring, this is what we call as infantile type. It's an infantile type. This is where intra-abdominal communication, it will be congenital type. And the last one is the hydrocele of the cord. There will be hydrocele of the cord. So there are the different types that are going to be present. Now, how does a patient of hydrocele going to present to us? Clinical presentation. So when you look at the clinical features, they'll present to you as painless inguino-scrotal swelling. The presence of inguino, that is painless inguino-scrotal swelling. There will be presence of a painless inguino-scrotal swelling. Now this painless inguino-scrotal swelling will have, number one, fluctuation sign positive. It is a fluctuation sign positive. It is irreducible. This is irreducible. There is a negative cough impulse. You can get above the swelling. You can get above the swelling. One second, class. Right, so there's a penis inguinal scrotal swelling, fluctuation sign positive, irreducible, negative cough impulse, can get above the swelling. You can get above the swelling. There is loss of scrotal rugosity. There's a loss of scrotal rugosity. The scrotal skin is going to become planed out because of extension. Okay? Now, there is small exception to this rule, that is when you talk about the congenital type of the hydrocele. In the congenital type of the hydrocele, you will notice, number one, it is reducible. Number two, there is a positive cough impulse. There is a reducible and it is having a positive cough impulse. Like it is almost like a hernia. Okay? Investigation that you can do for hydrocele is the ultrasound of the inguinoscrotal region. It is going to be the ultrasound of inguinoscrotal. Ultrasound of the inguinoscrotal region. Right? How would you like to manage? The management is going to be surgery, and there are two surgeries that you have to remember for hydrocele. One is going to be your Lodge's procedure, another one is going to be Jabelois procedure. One is Lodge's procedure, another one is your Jabelois procedure. Lodge's is basically sac plication. It is a sac plication. Jabelois is basically sac eversion. Jabelois is basically sac eversion. Okay. So this is all the important topics in your urogenital system that has been asked in our exam. So far, any questions? Quick feedback. So far, any questions? Quick feedback. Any doubts? Okay. Do you want me to cover any other topic? Right. So if you have no further questions, if you have none to ask, there's another session of Farre that is going to be from 8 o'clock to 10 o'clock. And we'll discuss the other questions there. So do join us at again 8 o'clock today, and we'll have another series of Farre. All right. Until then, thank you so much, guys. Good night. Take care. See you at 8 o'clock. Bye bye.